Thank you for joining us today for following the twisted trail of a Medicare claim. So far today, Leanne has taken you through the process of provider enrollment. Jennifer has discussed documentation practices along with common errors and denials related to documentation. Then, depending on what type of claims you bill, Aline walked you through how things work for FISS or actually guided you through the MCS submission. So now here we are. We're talking about what happens after those claims enter FISS or MCS and the process they have to go through to get to that finalization. Now, I do have just a couple of things to cover before we get started. The Training Center webpage is where you can find information related to the provider outreach and education team. Because this is an all-day event, we were not able to post our presentations to the Training Center like we do for other events. I did email a copy of the presentation yesterday and then again earlier today for anyone who had registered. There may have been some who registered after I got all of that done. So if you've registered within the last couple of hours, I wasn't able to get that out to you. So if that is the case, and if you do want to have a copy of this presentation, then please contact our team by emailing the education mailbox at wps.gha.education@wpsic.com, and I'll make sure to get that out to you. Well, the Training Center is also home to our Encore Presentations webpage. All of our webinars are recorded, and if there's no technical difficulties, the videos are posted to our Encore Presentation webpage along with our YouTube channel. Videos are available for up to 90 days and can be watched on our webpage without having to go to YouTube. Now, after that 90 days, the video is removed from the Encore Presentations webpage, but it will remain on our YouTube channel until the information needs to be updated. Again, we are seeing some positive responses to our Medicare Education Expo. Each session is getting about 200 or more registrants. Many of you did submit pre-submitted questions during the registration process. These have been reviewed, and where appropriate, I've tried to integrate them into today's presentation. Now, we also will be holding a question and answer session on Tuesday, October 21st. So if we have time at the end of the webinar, I will take questions that are entered into the chat. If there's any questions that we don't get to, I will send out questions and answers to everybody in attendance. So they will get answered. And here's a disclaimer. I won't read it to you. I just need to let you know that CMS does prohibit recording of this webinar. We are recording the event so it can be posted as an encore. So if there's anything you missed or you want to share, you will be able to view it again. Now today I'm going to take you through the path of a Medicare claim. This is what it follows every time a claim gets entered until it reaches finalization. So I'm briefly going to talk about post-adjudication action, but it is going to be an overview since details are going to be covered in today's final webinar. Now, anybody who has been in Medicare for some time knows that it contains a lot of acronyms. Now, I have created a list of those that you will see or hear during my presentation. Many of you may be aware of most, if not all of these, but I do like to include them just in case there's someone who's new to Medicare or maybe someone who works in a field or a practice where they haven't need to know what these terms mean. So if I do mention a term or an acronym that you're not familiar with, then you do have these slides for reference. So we're going to start with some general guidelines for Medicare claims. I'm going to keep this high level as the information may have been covered in earlier sessions. A federal law requires that any provider who is enrolled in Medicare must submit a claim to Medicare for any covered service furnished to a beneficiary. Most providers, physicians, and suppliers accept Medicare assignment. They bill Medicare directly and they agree to charge the beneficiary only for deductible and coinsurance. Now, some physicians and suppliers do not accept assignment, and they are referred to as non-participating. So they choose to accept the Medicare approved amount on a case-by-case basis. Now, doctors and other healthcare professionals may also choose to opt out. Now, this means that they don't want to work with the Medicare program. Medicare will not pay for services received from this provider unless it is an emergency situation. When a claim is submitted to Medicare, it must be done within 12 months from the date the services were received. There are rare exceptions where this requirement may be waived. In general, the from date on the claim should be used when determining the 12-month timely filing period. For institutional claims that have span dates of service, so this can occur if a person is in an inpatient hospital, so their claims may span a date, then you're going to want to use the through date in order to determine that date for timely filing. There are a few ways that claims can be submitted. The Administrative Simplification Compliance Act requires that Medicare claims be sent electronically unless certain exceptions are met. So if you qualify to submit paper claims, institutional claims are submitted on a CMS 1450 form, also known as a UBO4, and professional claims are sent using the CMS 1500 form. Some of you may have attended the earlier sessions when they went over how to bill using these forms. DDE is an option that is available for Part A providers that use the Fiscal Intermediary Shared System, or FISS. Part B providers who bill on the multi-carrier system do have the option of entering claims using the WPS Secure Net Access Portal, or SNAP. You will usually hear this referred to as the portal. And lastly, we have EMC batches, which is our most common form of claim submission. So let's take a closer look at these options. The ASCA requires that all initial claims be submitted electronically as of October 16, 2003, with limited exceptions. First, I want to define an initial claim. These are claims submitted to the MAC for the first time. So this includes previously rejected claims, claims with paper attachments, demand bills, claims where Medicare is a secondary payer, and non-payment claims. What initial claims do not include are adjustments or claims corrections to previously submitted claims or appeal requests. Now, the first exception to this rule is small providers. The Code of Federal Regulations defines a small provider as a provider of service with fewer than 25 full-time employees, or a physician, practitioner, facility, or supplier not otherwise mentioned in Section 1861 of the Social Security Act with fewer than 10 full-time employees. Other exceptions are based on limitations to the claims transaction format. Roster billing falls under this exception. So although claims for flu shots and other vaccinations can be submitted electronically, it's a one claim per patient submission. So I'm sure we've all seen signs at our local grocery store or our pharmacy, and it reads, "Get your flu shot today." So imagine if those administering the vaccines had to bill a claim for each individual that came in. A roster billing allows suppliers to submit a single paper claim. They put the basic provider and service data on there, and then they attach a list of Medicare beneficiaries who received the vaccination. Some Medicare demonstration projects may specify that paper claims have to be submitted. Demonstration projects test something that is not previously done, and for this reason the service may be something that is new, or it may not have been included in an accepted code set. So if the demonstration project requires data that is not supported by an existing HIPAA format, then Medicare could mandate that those claims be submitted on paper. There are also two MSP situations in which a paper claim may be submitted. The first is obligated to accept as payment in full claims when there is more than one primary payer. These are claims where the provider, the physician, or the supplier has agreed to receive a payment rate that is higher or lower than the payer's normal allowed amount as payment in full. The other MSP situation is when there is more than one primary payer and more than one allowed amount. This occurs when a beneficiary is covered by more than one primary payer. And while the system currently allows payment information for more than one primary payer, it does not allow for reporting separate allowed amounts at the line or claim level for more than one payer. So for these reasons, paper claims would be allowed. Completed claim forms should be mailed to WPS at the address shown on our website. I think I do have a link to that on the resource slide. Now, DDE is for Part A providers, and this allows providers who submit claims on the UB04 to enter claims directly into FISS. Users will need to establish a connection to the DDE system by working with a CMS-approved network service vendor. These are entities that provide connectivity services, but they don't have access to the content of the data that's being transmitted. Approved network service vendors that have successfully completed testing with WPS are posted on our website. Now, once the connection is in place, there are forms that have to be completed. Each facility will designate what's called a DDE authorized signer. The signer has to register for a DDE submitter ID by completing the DDE submitter ID request form. These forms can be submitted and sent to WPS right from our website. To access DDE, a request has to be submitted by that authorized signer, including the DDE electronic access request form. Other items that have to be in place are an EDI enrollment form and the data direct entry EDI enrollment form. So I know this is a lot of information. We do have instructions on our website, so don't feel like you have to remember all this right now. The option of submitting claims through the portal is available only for Part B providers who submit claims on the CMS 1500 and have not already registered to submit electronic claims through other EDI methods. Users will need to register for portal access. When you visit the WPS website, there's a large box near the top right of the screen. If you are already registered, you can enter your ID and password. If you haven't registered, I've included a link on this slide, but there's also a link under the user ID box on our website. Access will need to be approved by your MPI administrator. There is a separate claim entry registration that will include the EDI Express enrollment form. The WPS EDI staff will notify you when enrollment is complete, and this process can take up to 30 days. Now, most of our claims that are submitted to WPS are done with EMC claim batches, which involves submitting files in an 837 format that contain multiple claims. Users can register on the WPS Medicare EDI website. I've included a link on this slide, but it can also be found in the quick link section of the WPS homepage. Users will need to indicate if they will be filing directly or if they will be using a clearinghouse or billing service. After registering for a trading partner account, testing will be performed in order to complete the process. So now let's start at the beginning of this trail with claim entry. There are 4 ways to file a claim. There are basically 2 different ways for claims to enter the system. A claim can be directly keyed into the system. So this is what happens when a paper claim is keyed by internal staff or when a provider enters a claim via DDE. Once you store the claim, it's there. You can see it in the system. The other way is EMC batches. Now this involves loading 837 files into the system. Now, this also occurs with paper claims that are sent to our office. Claim forms are scanned using optical character recognition equipment, and this converts the data into the format for the 837 files. Claim data entered through the portal is also converted into 837 files. Now, EDI submission involves entering claims into an electronic claims processing software. The one I am familiar with and is offered through WPS is called PCACE. Again, you will enter claims data, which will then be converted into an 837 file format, which can be submitted to Medicare. Now, before the claim ever gets loaded into FISS or MCS, there are points along the way where data is being checked to make sure that it's formatted correctly and that there's no missing or invalid data. The first stop is the MAC translator. So the first level of notification is called a TA1. It's also known as an interchange acknowledgement. And this notification is received immediately, and it's only generated if your whole claim file has been rejected. Usually this is due to some type of formatting error. So if you receive this report, the entire file is rejected, nothing's going to get through. So you'll need to make corrections and resubmit. If no report is generated, your file is past the first level of edits. The next notification is called a 999. This is also a response to the translator receiving a claim file. Now, this notification can come anywhere from 5 to 15 minutes after the claim was received. The 999 is going to let you know if your file was rejected, accepted, or accepted with errors. Now, examples of errors causing a reject would include things such as an invalid character, a missing or incorrect data element, things like that. Accepted with errors means that overall the file was formatted correctly, but maybe a couple claims within the file had errors such as an invalid zip code or a misformatted NPI. Now, files that are accepted or accepted with errors will move into the Common Edit Module or CEM. The 277CA file is generated by the CEM, and it's going to give you information on whether the individual claims within your file have been accepted or rejected. So depending on the number of claims within a file, it could take up to 25 minutes for this report to be generated. Now, if a claim has been accepted, the 277CA is going to show you the claim number, which is often referred to as a DCN or an ICN. This can be used later when you're checking claim status inquiries, things like that. If an individual claim number is not assigned, then you're going to need to review the claim status code and the claim status category codes provided to determine why the claim was rejected. Then once you determine what's wrong, then the error will need to be corrected and the claim will need to be resubmitted. Now, paper claims that are scanned using OCR equipment are also checked for missing or inconsistent information. Those that are accepted will be converted into the 837 format for submission to FISS or MCS. So your claim has finally made it into the system. What happens now? Well, until this point, your claims have only been checked to find formatting issues. Now that it's in the system, everything else is going to be checked. This is not an all-inclusive list, but I did try to cover a wide variety of edits. Does the claim have the right beneficiary information? Does the name and the Medicare number entered on the claim match what's on the Medicare card issued by Social Security? Does the patient have the right coverage for the type of claim being billed? So if there is a premium for Medicare Part B, so maybe some people may not enroll in that. So if you submit an outpatient hospital claim, the system's going to check and make sure that the beneficiary is actually entitled to Medicare Part B. The system is going to check to see if there's other claims from the same provider for the same service date, or if it's overlapping a claim from a different provider. Medical necessity is a big one. In Medicare, you're always going to hear the terms medically reasonable and necessary. So the system's going to check for that. Now, the National Correct Coding Initiative consists of 3 components. There is the procedure-to-procedure edits that verify code pairs can be billed together. The medically unlikely edits, that sets a maximum number of units for a specific code that is considered medically likely for a single service. And add-on code edits that ensure add-on codes are used correctly in conjunction with their primary procedure code. The outpatient code editor is a software system used to process and edit outpatient facility claims for accuracy and to ensure correct coding, while the Medicare code editor is used primarily for inpatient hospital claims. Now, I was asked a question about rural health clinic claim cycles. Rural health claims are going to follow the same path as any other claim. Now, there may be edits that are going to check a rural health claim that aren't going to check an outpatient hospital claim. So for example, if a claim is billed with an MPI for a rural health clinic, the system is going to make sure that the type of bill is a 111 for an original claim. So hopefully that makes sense. Now, as a claim moves through the trail of edits, various actions can be taken. In FISS, a claim can suspend, meaning that it is waiting for action to be taken from internal staff or the system. It can be returned to provider. If this occurs, it means that there's an error that's found and the claim is sent back to the provider for correction. Once the correction is made and the claim is stored, it's going to move back to the beginning of the trail and it's going to go through these edits all over again. The system may generate an additional documentation request that's asking for medical record documentation. ECPS is the Expert Claims Processing System. This is a program that is written into FISS that will work claims and eliminate the need to involve internal staff. Now, not all claims can be worked by ECPS, but there are quite a few that the system just works for us. Now, if it is found that the services do not meet Medicare's requirements, it may be rejected or denied. On the other hand, a claim can be found to meet all the requirements, there's no errors in it, and it's just going to pass right on through to the next step. Now, I wanted to include some common status locations that you might see with your FISS claims. SB 6000 is a location that the claim will be in when an ADR is generated. The claim is then going to move to status location SB 6001, letting you know that it is waiting to receive that additional information. SB 9000 is when the claim is at the beginning of the trail and it's going to pass through the edits that we discussed. When a claim has been RTP'd, after the provider makes the correction and stores the claim, it's going to move back to SB 9000 because changes have been made. So it has to make sure that it goes back through all those edits and nothing's wrong with it. The SMXXXX, this is a location. So those X's could be numbers, they could be other letters. This is a location that's worked by internal staff. The M means that the claim was manually moved. So sometimes staff in our systems department will use these locations to hold claims when a technical issue has been discovered and we're waiting for a fix. That way the claim isn't rejected or denied incorrectly, which could lead to having you to do a rebill or adjustment claims. If you just hold those claims and you wait for the fix to come through, then those claims can be released and they can process correctly. SMECPS or SMSUP with like a number after it, that is a location where ECPS is going to work the claim. ECPS is run daily, so claims should not sit in that location for too long. SM hold is a location that you're going to see around the time of a quarterly release. The processing system sends updates in January, April, July, and October. These updates include edits, pricing, and other claim processing updates, and claims will normally be held for up to 14 days to ensure that they process correctly. TB 9997 is the location for claims that are returned to provider. So once it's in this location, providers can make any needed corrections that they need to do to their claim. PB 9996 is when a claim has made it to the payment floor. Then once the payment has been issued, the claim is going to move to PB 9997, which would be the end of the trail. Now for MCS, the actions that are taken can be a little different. You might notice that there's no suspense or return to provider listed here. For MCS, a claim that contains incomplete, invalid, or missing information cannot be processed for payment and it's considered unprocessable. These claims are technically not filed with Medicare, so providers will need to identify the error and submit a new corrected claim. The remaining actions are the same as what's in FISS. We have an additional development request that will be generated requesting medical documentation to support services billed. And also a claim may reject or deny, just like the FISS system. And it can also, again, pass through all the edits. Everything looks great, and it's going to move on to the next step. Now, I want to talk a minute about additional documentation requests. These are formal requests from Medicare asking a healthcare provider or a supplier to submit medical records and other supporting documentation for a specific claim. The purpose of requesting this information is to verify that the services billed to Medicare were medically necessary, that they were coded and billed properly, and that the patient's medical records support the services that were provided. Documentation is also reviewed to ensure compliance with Medicare's rules and regulations. Providers or suppliers should submit the documentation within 45 days, and after that time, if records are not received, the claim will be denied for no documentation. Now, you may hear the words reject or deny used interchangeably, but there is really a difference. If a claim is rejected, it's due to a technical error. Maybe the name submitted on the claim doesn't match the name listed on the patient's Medicare card, or maybe it's a duplicate, or it should have been submitted to another payer before it was sent to Medicare. So depending on the rejection, the provider can submit a new claim. Adjustments and reopenings are actions that can be taken on a processed claim. Adjustments are made within the FISS system, and it allows providers to make changes to a processed claim. This process allows providers to correct an item or a service that was not included on the original claim. Reopenings correct or supplement information that was already included on the initial claim. And allow for the correction of a minor clerical error. So examples would include transposed codes or correcting a provider number, a modifier, or a data service. So something that was already on the claim, there was just some sort of error with it. Now, denials are due to policy. So, for example, the services were not medically necessary or they're not covered by Medicare. Maybe prior authorization was required, but it wasn't obtained. These services cannot be corrected by the provider and they will need to be appealed. Now, you're going to know if a claim has appeal rights because on your remittance advice, you're going to have that RARC MA01. So that lets you know you have appeal rights, you can do something with it. Many registrants asked for the top rejections and denials. For FISS, the number one reason is timeliness. So claims are not being submitted within the 12-month time frame. The second reason is that claims are submitted to Medicare without billing the primary payer. That's our second largest reject code over in FISS. For denials, most of the ones in FISS are related to LCDs. Now, for MCS, it is a little harder for me to tell what codes are rejects and what codes are denials, but the top reasons that I found are collection of fee for service during periods of managed care. That was number one. Billing a duplicate charge comes in second. And the procedure code submitted is a non-covered Medicare service came in at number 3. Now, after the claim has moved through the claims processing edits, a claim is going to go down the path to the Common Working File, or CWF. CWF is a central system that houses all Medicare Part A and Part B beneficiary data and claim history. It acts as a master record, and it's comprised of nine localized databases. Each beneficiary is going to be assigned to one of those localized databases. We call them hosts, and their assignment is going to be based on geographical location. Now, there are some edits that run in the Common Working File. Common Working File is updated nightly, so anything that comes into a specific MAC is going to be processed out to Common Working File and post out there. The beneficiary data streamlining, this is a process that checks beneficiary eligibility and entitlement early in the process, which allows for faster processing of the if the information doesn't match Social Security's records. So we kind of hit that right away. If it doesn't match, it's rejected, and then it doesn't go any further. The fraud prevention system is another process that uses analytics and other technology to proactively prevent, detect, and investigate potentially fraudulent claims before they're paid. I know a lot of times, like with these rejects, it just kind of says FPS and you don't get a lot of detail on it. I don't know if it's because it has to do with the fraudulent stuff, but I just haven't seen a lot of detail on those edits. Now, earlier we talked about claims edits within FISS or MCS. And when a claim makes it to Common Working File, it kind of goes through another set of edits. But now, instead of editing against other WPS claims, it's being checked against claims that have been submitted by all the other contractors. So when you go out to Common Working File, you've got WPS claims, you've got Noridian, CGS, everything goes out there. So you can kind of see where it's going to start checking for duplicates again, things like that, just to make sure we're not overlapping somebody else. The Common Working File edits are broken down into 4 categories. Consistency edits verify that the claim information is consistent across different parts of the claim for payer types. Utilization edits ensure that a beneficiary's benefits do not exceed program limits. So for example, Medicare beneficiaries are entitled to 100 covered days in a skilled nursing facility per benefit period. If we just look at the WPS system, we aren't taking into account skilled nursing claims that could have been processed by other contractors. So we may think that the beneficiary has days left when in fact they could be benefits exhaust. So it's going to look for things like that. AB crossover edits are going to ensure that services paid on a Part A claim aren't also included on a Part B claim. There's also edits put in place to make sure the claim isn't a duplicate. Now, all of these edits mean that a claim can make it through FISS or MCS, but when it is sent out to Common Working File, it can be rejected because of data contained on the master record. Now, our next stop on the trail to payment is HighGlass. HighGlass is a component of the Department of Health and Human Services Unified Financial Management System. Once a claim has passed through all of the claims processing systems and the Common Working File edits, HighGlass is going to perform payment calculations, formatting, and accounting, which ensures accurate reimbursement. Medicare payments are tracked and reported to CMS by using HighGlass. It also supports the federal payment levy program by collecting overdue taxes from certain federal payments. So now that our claim has made it down the trail of FISS and MCS edits, it's gone through Common Working File, it's gone through HighGlass, it's going to arrive at the payment floor. Now, the payment floor is where the initial claim determination will be finalized. How long a claim waits on the payment floor is determined by the day the claim was received and how the claim was submitted. If a claim is submitted electronically, the wait period is going to be 14 days. So this is going to include claims that are submitted through EDI, DDE, and the portal. Paper claims are going to have to sit on that payment floor for 27 days. This is going to be paper claims that were received by mail or fax, and those that were loaded via OCR technology. So we finally made it to the end of the trail. We're at finalization. Now, I'm not sure if all of you are aware, but MACs also have a deadline for processing a clean claim. As a provider or a supplier, you have 12 months to submit your claim to Medicare. If that claim meets the criteria of a clean claim, then we have 30 days to get that claim paid or denied. And the clock starts counting the day after the claim is received. And if the deadline is not met, then we have to pay you interest on that claim. So what is the criteria for a clean claim? Clean claims must pass all edits within FISS or MCS as well as Common Working File. Claims that do not require external development, so this means that the claim is not suspended to be worked by internal staff or returned to the provider for correction. The claim has all of the basic information necessary to process and all required supporting documentation. So this means that if the claim is subject to medical review, all relevant documentation is attached. They don't have to come back to you and ask for anything. And once that claim process is done, the system still does have action to take. Payments are issued. In some situations, this may be a check issued to the beneficiary, but for most of the time, it is in an electronic funds transfer or an ETF to the provider or supplier. Remittance advices are generated. Most of these are sent electronically in the form of an 835 file. While paper remittance advices can be generated, I do not believe that they are sent out very often. I seem to remember quite a few years back, there was really a push to get everybody onto that electronic claim form or ERA form. MSNs are issued to beneficiaries to show a summary of the services and supplies that were billed to Medicare, what Medicare paid, and if there's an amount that is owed to the provider. You're also going to notice secondary payer on the list for finalization actions. Now, if we receive a claim and it contains secondary payer information, so the beneficiary has Medicare as their primary insurance, but let's say they have Blue Cross Blue Shield as their secondary. Now, if Medicare has a trading partner agreement with that insurance company, we're allowed to send claim information to that supplemental insurance company. Now, if beneficiaries have a supplemental insurance that does not have this agreement with Medicare, then that would require you, the provider, to file a claim directly with that insurance company. So now you may be thinking, we've gotten to the end of the trail. My claim's finalized. I've gotten my payment or notification of rejection or denial, so we're all done, right? Well, action can still be taken. Post-payment review of a claim can take place. Now, I'm not going to go into much detail because today's final webinar is going to cover post-payment reviews in detail. So post-payment reviews can be done by the WPS Medical Review Department for the same reasons that we talked about earlier. We need to make sure Medicare is paying for services that were medically reasonable and necessary and are coded correctly. There's also target, probe, and educate that can occur pre or post payment. This is a required process for providers who have been identified by data analysis as having a potential for fraud, waste, and abuse. There is a certain number of claims that are reviewed within a certain time frame. So this doesn't affect everybody. It would just be, as the title says, targeted. So it's targeted at certain providers. A recovery audit contractor, or RAC, they are a third-party company that is hired by the government to find and correct improper payments made to healthcare providers by Medicare and Medicaid. There's also a comprehensive error rate testing, or CERT, contractor. This is a company that reviews a random sample of Medicare fee-for-service claims to ensure that they were paid correctly. The post-adjudication action can also be taken by you. Earlier, we talked about FISS providers who were able to submit adjustments to paid claims. MACs may also adjust claims. Some of you may be familiar with mass adjustments. This is normally done due to a systems issue. So maybe it was discovered that a code was priced incorrectly. So once a fix is received, CMS may instruct the MACs to take all of the claims that were processed with that incorrect code and then adjust them so that they can pay correctly. Reopenings are done after the claim is finalized. Maybe you realize that a modifier was left off the claim or an amount was billed incorrectly. Then lastly, we have appeals. So if your claim was denied and you have appeal rights, a redetermination request can be sent through the portal or in writing. Now, if your claim is changed by either the adjustment or the reopening process, again, it's going to start at the beginning of that trail and it's going to go through the whole process that we covered today. Now, I have provided you with some resources that I hope you'll find helpful while navigating this whole process. I don't want to go through all of them because I do want to get through a couple questions that were pre-submitted, but hopefully these will be helpful for you. So before I go over to Mary Sue, I do want to address a couple questions. The first question I got was how to file a claim correctly within the portal. So on the resource slide, this link right here, the portal user manual, this does have instructions for how a Part B provider can submit claims. We are also currently holding education on each of the functions available within the portal, so it will be a future webinar topic as well. Another question was, I want to know how to avoid and stay up to date on edits, deletions, and other issues causing rejections and denials. Now, since all of our guidance comes from CMS, the best way to stay up to date is to subscribe to their emails and newsletters. I'm going to have Mary Sue add a couple links into the chat. The first one, which is like a cms.gov web policies, important links, email updates. This is going to allow you to sign up for CMS topics that interest you. The other link that ends in Medicare Learning Network / newsletter, this lets you subscribe to the weekly MLN Connects newsletters. Now, I actually subscribe to both of these links, so I get emails every week with CMS updates and things like this. I am a huge supporter of the MLN Connects information because I feel like it takes, the government regulations, they can get really complicated, they can get really wordy, and that MLN Connects just seems to take the information and they put it in a format which I find is much easier to understand. So I always promote the Medicare Learning Network or the MLN. I always promote them whenever I can. The last question that I'll cover, and then I'll switch to Mary Sue real quick, is why do we not get a notice when our claim is rejected? So when a claim is rejected, you should be receiving notification on your remittance advice. I'm not sure how you submit claims, but if you use a clearinghouse or if you use a third-party vendor, you're going to want to make sure that you have access to this information. There's also, I know sometimes like with DDE, if they're going through vendors, these vendors can manipulate information or they can leave certain information off, so you're not seeing the data exactly the way that we send it. So if that is what your situation is, you may want to do some deeper checking into your vendor and making sure you have access to this information. Now, the portal and the IVR are also tools that can be used to verify claim status. So if you're checking your claim status, which we do recommend that providers check that at least on a weekly basis, you should be getting notification that your claim's rejected. Now, if you are talking about electronic file notifications, so like if you're saying that your claims aren't even making it into the system, so you should be getting things like a TA1 or a 999 or 277CA. Now, this is also something that you're going to want to make sure that your vendor is giving you access to receive. So unfortunately, all of the information that is coming out of our office should be showing that claim is rejected. But since I don't know how you're getting that information or who's providing you with that information, that's the best advice I can give you. So I will turn it over to Mary Sue real quick and see if we've had any questions come through in the chat.
Karen, yeah, there's a couple questions that I didn't get an answer to. They're both kind of to do with coordination of benefits. So I put a general link to the coordination of benefits information page into the chat, just so everyone knows why I put that there. But I'll give you the first question. For secondary payer, is this the same as crossover to the secondary payer?
I don't know if they're talking about when I don't know if this is when I was talking about supplemental insurance. If we have a contract with the supplemental insurance company, then we will submit the claim information to the supplemental. So we'll pay the claim, we'll forward it to the supplemental, and they'll have our information. Now, again, we have to have a contract with them to do it. One of the ways that you can tell if we have a contract with them is that if you have access to our portal and you do an eligibility check, after you enter the patient's information, there's two buttons. One says eligibility, one says supplemental insurance. If you click on that supplemental insurance button and and the insurance information that you have is showing on that tab, that means that we have a contract with them and we're going to forward it. So hopefully that helps.
All right, and your next question comes in and it says, how does the beneficiary add their supplemental information if claims aren't crossing over? Usually Medicare tells them to call the supplement tells them to call Medicare. Would it be the BCRC? I get a lot of confusion with patients and want to make it easier for them.
That I would go to the BCRC. So the link that Mary Sue gave you, I would go to that because that's, if we don't have a contract with them, there's really nothing that we can do. We also cannot update MSP information. So if we have something on file and the beneficiary is like, oh, I don't have that insurance anymore, I have this insurance, nobody here can change that. That all has to go through the BCRC.
Perfect. And then one last question. I know we're getting close on time. How often is coordination of benefits? I'm assuming that's what they mean, COB. How often is the coordination of benefits info requested to be completed from the patient for secondary?
If you're talking about like the Medicare, like the admission questionnaire, that information, I think it's every 90 days. Every 90 days, CMS recommends that a provider kind of refresh that with the beneficiary and make sure that the information is still the same. I think that's what they were talking about.
Yeah, and the follow-up is that they see a lot of incorrect crossovers. That the same person that asked that question.
Yeah, so yeah, the same thing. Like if that information is incorrect, unfortunately, we don't have access to it. So that all has to go through the PCRC, unfortunately.
Okay, and that takes us to the end of questions that were not answered in the chat.
Okay, great. Thank you, Mary Sue. So after the close of today's webinar, you will receive a thank you for attending email. There are two sections that I would like to draw your attention to. The first section is titled Your Opinion Matters. This is going to give you an opportunity to provide feedback if you've not already done so. The second section is titled Certificate of Achievement, and this gives you proof of attendance and contact hours that can be submitted to your crediting organization for continuing education units. Now, if you don't get this email, check your junk or spam folder. You'll also need to add messenger@webex.com to your safe sender list. That'll avoid this issue in the future. Now, if you joined by phone, WebEx is unable to generate this email. So we do ask that you send an email to the education mailbox, and please include your name and your phone number that you used to join so that we can get a certificate sent out to you. Now, if you think of questions after the webinar, you do have 7 days to send those in. You can email those to the education mailbox shown here on the screen. Be sure to put today's topic in the subject line so that staff knows that your question is related to this webinar and they're going to send it directly to me. Remember, if your question is claim specific, those should go to customer service. We are also having a Q&A, like a follow-up Q&A session for the Medicare Education Expo. That's going to take place on October 21st at 1 p.m. Central Time. Mary Sue will put some information in the chat about that. Now, when you disconnect from the webinar, you are going to be redirected to a CMS survey. I'm also having Mary Sue add a link in the chat. Now, I really do hope that you'll take a moment to provide feedback on how I did today. The redirect is going to look like what you see here at the bottom of the page. We show it to you. We don't have any control over how this looks, so we just want you to know it's not spam, it's nothing malicious. You just hit the blue continue button and it'll take you to the survey. So what do we do with survey comments? Well, here's some of the recent changes that we made because of survey comments. Our Medicare education expos are because as a community, you have let us know what education you want us to provide. We are thinking of holding another one at the beginning of the next year. So if you have a topic that you think would be great for education expo, let us know and we'll take it into consideration. Well, that does bring us to the end of today's presentation. On behalf of myself, Mary Sue, and the Provider Outreach and Education team, I would like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.